Hello everyone, my name is Shari Cohen and I'm going to be moderating the webinar today. I'm the Director of Public Health at the Hepatitis B Foundation. Hepatitis B Foundation is the only national nonprofit organization dedicated to addressing hepatitis B and liver cancer locally, nationally, and worldwide. The Hepatitis B Foundation also co-leads Hep B United, which is a national coalition of 17 coalitions around the country working towards eliminating hepatitis B. Before we get started, just please take a few seconds to respond to the poll, which is going to be posted to your everybody should have the poll now. So if you can just take a second and respond to the poll on your screen, we want to get a better understanding of who our audience is today. We're going to have the results out in just a few seconds. Well, that was fast. So if you take a look at the results, it looks like we have some really good participation from local or federal government, healthcare facilities, and social service and community-based organizations. So thanks everyone for participating today. We know it's going to be a great webinar. On behalf of Hep B United, I would like to thank you for joining us for the webinar, which is entitled Hepatitis B and Reducing Perinatal Transmission, an overview and discussion of new tools. This is a collaborative effort with the White House Initiative on Asian Pacific Americans and Pacific Islanders, and we're excited to present today about the importance of early interventions to reduce and eliminate perinatal hepatitis B transmission. Joining us as your presenters today are Dr. Seiji Hayashi, Chief Medical Officer of the Bureau of Primary Health Care at the Health Resources and Services Administration of the Department of Health and Human Services, Dr. Trudy Nisi from Centers for Disease Control's Division of Viral Hepatitis in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention, Dr. Sue Wang, former Assistant Director of Medical Affairs at Charles D. Wang Community Health Center and current Medical Director of the Center for Asian Health Chinese Health Initiatives at the St. Barnabas Medical Center. We also have Dr. Deborah Wexler, who is Executive Director of the Immunization Action Coalition. We're just going to do some housekeeping before we get started. I wanted to go over a few of the housekeeping items and let you know how you can participate in today's webinar. If you look at your screen now, this is an example of the GoToWebinar attendee interface, which is made up of two parts. The window viewer, which is what you're looking at on the right or the left, depending on where your browser systems are. That allows you to see everything the presenter shares on the screen. The control panel should be on the left, but it also might be on the right, depending on your computer. That control panel is what allows you to participate in the webinar. If you note that all attendees are in listen-only mode, and everyone will stay muted, if you're just an attendee, you'll be muted during the entire presentation. By clicking on the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. You can submit questions in writing during the presentation by typing them in the questions field. And just please make sure when you do submit a question that you indicate to whom the question is directed out of our speakers. We will be reviewing the questions as they come in today, and at the end of all of the presentations, there will be a Q&A period. Today's webinar will be recorded, so you will have very soon an email with a link that will allow you to view today's presentations. Finally, before I pass the meeting over to our presenters, I wanted to let you know a little bit about the White House Initiative on Asian Americans and Pacific Islanders and about Hep B United, who are the co-hosts for the event. The White House Initiative on Asian Americans and Pacific Islanders represents the fastest growing racial and ethnic minority group in the United States. Their mission is to work with all agencies of the federal government to improve the health, education, and economic status of our Asian American and Pacific Islander communities. Next slide, please. Hep B United is a national coalition that is addressing the significant public health challenge of hepatitis B, which is the leading cause of liver cancer and a major health disparity among Asian Americans and Pacific Islanders in the United States. Our goal really is to help leverage and support the success of all of those coalitions around the country who've been able to help reduce the impact of hepatitis B in their high-risk populations. The purpose of the webinar today and our future webinars is to highlight what the priorities in the field of hepatitis B are. We hope that these webinars will provide you with some new insights and some new tools that we can all use locally, regionally, and nationally. Before we get started with our presentations, we have another quick poll, which will be popping up in just a second. Please take a second to answer this question for us. Okay, the responses should be coming in just a minute. Okay, folks, I'm still waiting for the responses, so just give me one more second. Okay, so in response to the question, what is your best estimate of the proportion of hepatitis B surface antigen positive pregnant women who receive prenatal testing for e antigen and/or viral load? It looks like the responses are pretty well split. About 28% said 10 to 25% receive e antigen testing. 21% that said between 26 and 50% receive e antigen testing. 23% said more than 50%, which is good, and it looks like about 21% said that less than 10% are getting e antigen testing. So it looks like we have some work to do ahead of us. Thank you for participating in the poll. Okay, so with this, I'm going to pass the meeting on to Dr. Seiji Hayashi, who is the Chief Medical Officer of Bureau of Primary Care at HRSA. As Chief Medical Officer, Dr. Hayashi oversees BPHC's clinical quality strategy for the nation's 1,200 health center organizations that operate nearly 9,000 sites. Dr. Hayashi?
Great, thank you so much, and thank you for the introduction. It's a real pleasure to be on this webinar. First of all, I bring greetings from HRSA Administrator Dr. Mary Wakefield and the HRSA Associate Administrator for Primary Health Care and the Director of the Bureau of Primary Health Care, Jim McCrae. And thinking about what am I going to say on this webinar, and rather than give you a boring bureaucratic speech, I want to tell you a little bit about my personal experiences working with patients with hepatitis B. And one case in particular that I remember very, very well. So about 15 years ago, when I was a family medicine resident at the San Francisco General Hospital, I cared for a 60-year-old Filipino man who was dying of liver failure. He had cirrhosis from hepatitis B. Actually, his final wish was actually to die in the Philippines, surrounded by his family. A few days earlier, he had actually gone to San Francisco International Airport to board a plane to Manila. And but when but he was turned away. When I saw him, he was gaunt, jaundiced, and his belly was swollen as if he were 9 months pregnant. He could barely walk, and he was delirious from, the toxins in his blood. I can only imagine what the flight attendants were thinking as they turned him away at the gate. They were probably worried that he was going to die on the plane. So he came to the hospital to be treated enough to make that 14-hour flight across the Pacific Ocean. And after talking to him and his family, I was really determined to get him on that plane. I called the airline first to find out, what they needed and under what circumstances they would allow him to board the plane. And what they said was that they wanted a letter from me stating that he was stable enough to fly. So over the next, week or so, I repeatedly stuck his belly with a large bore needle that was probably about 5 or 6 inches long. I took out over 2 gallons of water from his belly. We gave him transfusions of blood and other blood products, and not to mention, the whole host of medications. So I thought he was stable enough, and he actually went to the airport directly from the hospital. And, he took his letter, and in the letter I assured the airline that he was stable enough to fly. I certainly wasn't telling the truth when I said that, he was okay to fly. I was thinking about what could happen to him. That on plane was actually the least of my worries. I worried that he was going to have a seizure on the plane, or that he would be vomiting blood because his esophagus was bleeding again. These are common complications of cirrhosis. I worried about him until I received a call from one of his daughters and that he had made it to the Philippines. So I was very happy about that. But during the conversation with his daughter, she actually told me that she had hepatitis and that her mother has it as well. And they were scared that the same thing would happen to them. So I counseled them to go see a hepatologist and for the rest of the family to be tested. So this was 15 years ago, but I can still see in my mind this man's face, his tired yellow eyes, and I can, see even clearer his large belly. His belly, was large, it was bulging out, the skin was shiny and tight because of the fluid pushing against it, and the blue veins zigzagging across the surface of his belly. And, I apologize for being a little graphic, but this is what happens after decades with the disease. What we call a silent epidemic is not so silent in the last year or two. And I'm not even talking about people with liver cancer and how people suffer and die with that. So unfortunately, this wasn't even the first time that I saw a patient like this. And then once I moved to DC and I started seeing patients at a community health center, I continued to see patients with Hep B, although I actually saw more cases of hepatitis C. And those who had Hep B were mostly recent immigrants from China and East Africa. And these were the areas of the world where people came from and came to my clinic. And obviously, very few had any records of being vaccinated. So in my clinic, all I did was test, diagnose, report it to the health department, refer them on to a gastroenterologist. And back then, this is, 4 years ago, I really didn't have a system. I didn't know that I could have a system. I didn't have electronic health records. I tested, the patients when I remembered to do it, but only if I wasn't overwhelmed with other health issues or other patients. So when I joined the federal government and when I was asked to be on the planning group for the first HHS, Viral Hepatitis Action Plan, I was more than eager to help. I thought that maybe, I can put some of my experiences to use. And this is where the issue of perinatal Hep B transmission really got on my radar. As a family doc that previously did prenatal care and helped women deliver their babies, it struck me odd that perinatal transmission of Hep B still occurred. I asked myself, how could this be? We see pregnant women about 10 times during their pregnancy. We check the labs to make sure that, they've been screened. Routine prenatal blood tests, include Hep B. And it's on every prenatal sheet, that's in the medical records that I've ever seen. So how could this be? And then even if they didn't get the Hep B test, before they went to the hospital and they arrived at the hospital in labor, the hospital should do these tests. If the mom was positive for Hep B, then the baby will receive the immunoglobulin and the vaccine. So the baby should be fine. So I thought. So I was a little confused. So I began asking my friends and colleagues in health centers and other primary care providers what they thought were the reasons for this. And as usual, the story got more complex. They reminded me that there are multitudes of prenatal lab panels, and some don't include Hep B. The codes and combinations of blood tests differ from one lab company to another, and there are ample opportunities to for providers to choose a combination that didn't include a hepatitis B surface antigen. But you can always catch that, right? In the next visit, if you didn't order the lab or ordered the wrong lab. But what they told me was, many health center patients receive prenatal care at multiple clinics or not at all. If they got the prenatal care, the records didn't show up, or they didn't get transferred soon enough. Insurance was a big issue. For the uninsured, some providers and patients would choose not to do the Hep B test because of the cost, and they're hoping that the patient will have money later, or that at the hospital they would get the test. It also turns out that similar issues that happen in clinics also happen in the hospitals. And to be fair to the hospitals, the highest risk patients sometimes arrive at the hospital in labor with no records and unknown prenatal care history. So like many health issues, it comes down to access, the quality of care, and the cost. These are the things that we work on at HRSA and the Health Center program. And we try to make care accessible by funding primary care services in communities that otherwise may not have it. We work to improve the quality of care by supporting quality improvement infrastructure with technology, HIT, patient-centered medical homes, and whatnot. We also make these services affordable through federal funding and policies. But I realize that what we do in the Bureau of Primary Healthcare is a small piece of the larger puzzle, and we need help, and we need help from everyone. We certainly have been, working with our partners and stakeholders, the CDC, APCHO, and the White House Initiative and others. So in closing, I want to thank those that have dedicated themselves to combating this issue. And I look forward to learning more from the expert panelists who are on this call, so that I can, and I have certainly incorporated many of the techniques into my daily practice as I see patients at a health center today. And finally, I look forward to continuing our collaboration and partnerships towards eradicating hepatitis. So thank you so much for being on the call, and thanks for being a great partner. So I'll hand the phone back to Sherry.
Thanks so much, Dr. Hayashi. Thank you very much, particularly for pointing out what some of the barriers are to eliminating perinatal transmission of Hep B, and for the story, which was incredibly moving and highlights just how important it is for us to be addressing perinatal transmission. Thank you. Next, I am going to introduce Dr. Trudy Murphy. Dr. Murphy is with the Division of Viral Hepatitis at CDC, and she is also a member of the World Health Organization Working Group to estimate the worldwide impact of hepatitis B vaccine on the burden of hepatitis B.
Thank you, Dr. Cohen and Dr. Hayashi. Good afternoon. In this talk, I will review how we can eliminate perinatal hepatitis B transmission. But first, I understand that we have another poll. We're asking you for your best estimate of the proportion of hepatitis B surface antigen positive pregnant women who are not identified by the Public Health Perinatal Hepatitis B Prevention Program. Sherry, will we be getting an answer soon? Oh, good. I think here we go. So 5 to 25% or even up to 50% or more, that's really astounding. And thank you so much for your answer. So now, next slide, please. First, some background. Hepatitis B is an infection of the liver caused by the hepatitis B virus, or HBV. HBV is found in body fluids of infected people. These fluids include blood or serum, vaginal secretions, saliva, and semen. An infant can acquire HBV infection from mother to child transmission. This is called perinatal transmission. Infants can also acquire HBV infection from a chronically infected member of the household. Next slide. The natural history of, here it's coming, the natural history of perinatal hepatitis B infection is diagrammed here. 90% of infected infants develop chronic hepatitis B, which typically is lifelong. Infants with chronic hepatitis B carry a 25% risk of premature death from liver failure or liver cancer. Only a small percentage of infants become immune or resolve their chronic infection over time. Perinatal hepatitis B infection is almost always asymptomatic and therefore will not be recognized unless we look for it. Next slide. Why should we eliminate perinatal hepatitis B? The main reason is to protect babies from chronic HBV infection, which can lead to liver failure or liver cancer. Most morbidity and mortality from hepatitis B occurs in people with chronic HBV infection. Treatment for chronic HBV decreases liver damage and the chance of liver cancer, but there is no cure. People with chronic HBV also can unknowingly spread the infection. Next slide. So what is the risk for perinatal hepatitis B transmission? The important thing to remember is that all infants born to pregnant women with hepatitis B are at increased risk for perinatal HBV transmission. Without intervention, 5 to 20% of infants become infected when their mother's hepatitis B viral load is low, and 70 to 90% of infants become infected when their mother's viral load is high. And that is the reason for the initial question, how many women are screened for viral load or hepatitis B e antigen? Next slide. We can prevent most cases of perinatal hepatitis B transmission. The first step is to identify pregnant women with hepatitis B infection. All pregnant women should receive hepatitis B screening at the prenatal visit of each pregnancy using the hepatitis B surface antigen, or HBsAg test. A confirmed positive or reactive hepatitis B surface antigen result indicates acute or chronic hepatitis B infection. Uninfected pregnant women should be reassessed for risk of hepatitis B when they are admitted to labor and delivery. If a risk is suspected, screening should be repeated. The original hepatitis B surface antigen laboratory report, including either positive or negative results, should be placed in the mother and infant's birthing records. Persons with positive hepatitis B surface antigen tests, including pregnant women, are reportable to public health in every state. Next slide. The AAPI recommends that all pregnant women with chronic HBV receive a medical evaluation and possibly antiviral treatment. The initial evaluation includes, at minimum, testing for hepatitis B e antigen and/or hepatitis B viral load, and measuring liver enzymes such as alanine aminotransferase. The results of these tests identify women at increased risk for hepatitis B-related complications, and also infants who are at the highest risk for perinatal HBV transmission. Women with chronic HBV should be managed during and after pregnancy in collaboration with a provider experienced in hepatitis B infection. Next slide. Several algorithms are available to guide the medical evaluation of pregnant women with chronic hepatitis B. This example was prepared by a panel of experts convened by the Hepatitis B Foundation and is published in the journal The Female Patient. The algorithm provides guidance on the evaluation of pregnant women, but it also reminds us that this is the opportunity to screen household and sexual contacts for chronic hepatitis B and to appropriately refer them for vaccination or evaluation of chronic hepatitis B infection as appropriate. Next slide. Each year, the CDC estimates the number of births to hepatitis B surface antigen positive pregnant women. In 2009, the estimated number was more than 24,000. Next slide. To prevent perinatal hepatitis B transmission, infants born to hepatitis B surface antigen positive pregnant women receive post-exposure prophylaxis consisting of hepatitis B vaccine and hepatitis B immune globulin, or HBIG, administered within 12 hours of birth, timely completion of a hepatitis B vaccine series, and post-vaccination testing at 9 months of age and 1 to 2 months after the final dose. Testing includes both hepatitis B surface antigen to determine if there was infection and antibody to hepatitis B antigen, or anti-HBs, for immunity to infection. Infants who are not immune and not infected are revaccinated with another hepatitis B series and retested. Next slide. The efficacy of infant post-exposure prophylaxis is high, 85 to 95%, when administered according to protocol. Some breakthrough infections can occur. 5 to 15% of infants born to a subset of women, those with high viral load, become infected despite post-exposure prophylaxis. To prevent these breakthrough infections, clinical trials are now assessing the safety and efficacy of prenatal antiviral treatment for women with high viral load. If effective, this approach will further increase the importance of early medical evaluation of mother's liver disease and also help us to identify and prevent perinatal transmission. The results of some of the trials are expected as early as 2014. Next slide. Additional guidance on post-exposure prophylaxis can be found in the Advisory Committee on Immunization Practices recommendations shown here, a comprehensive immunization strategy to eliminate transmission of hepatitis B virus infection in the United States, Part 1. Next slide. As you have seen, preventing perinatal hepatitis B transmission requires a carefully timed series of prenatal and infant management steps. The U.S. Perinatal Hepatitis B Prevention Program was created by CDC in 1990 to educate, assess, and assist in the elimination of perinatal HBV transmission. Perinatal hepatitis B prevention programs are part of immunization programs funded by CDC in 64 public health jurisdictions. Program coordinators foster collaboration with healthcare providers, laboratories, hospitals, nursery personnel, and families with the following objectives. Next slide. To identify hepatitis B surface antigen positive pregnant women through reports to public health. To ensure timely initiation and completion of infant post-exposure prophylaxis with post-vaccination testing. And to encourage hepatitis B vaccination starting at birth for all newborn infants as a safety net for infants whose hepatitis B infected mothers are not identified. Next slide. The U.S. perinatal prevention programs working with healthcare providers have had increasing success over time. Together, from 1994 to 2009, more than 167,000 pregnant women with hepatitis B and their infants were case managed. More than 95%, and now in 2011, 97% of infants received hepatitis B vaccine and hepatitis HBIG by less than 24 hours of life. And the infants completed post-vaccination testing increased from 24% to almost 60%. In 2011, it reached 61%. Most important, the rates of perinatal hepatitis B among infants who were tested decreased from 2.5% to less than 1%. Next slide. To assist healthcare providers and programs, CDC has developed an array of resources, including the examples shown here: interpretation of hepatitis B serology, recommendations for routine testing and follow-up of persons with chronic HBV infection, flow charts for initial hepatitis B surface antigen screening and notifications during pregnancy and at delivery, and flow charts outlining the steps for prevention of perinatal hepatitis B transmission. Next slide. Materials are available in 12 languages to help pregnant women and their families understand how they can protect their babies. Next slide. An audio-visual educational slide set for women and families is also available in multiple languages. All of these materials can be downloaded from the CDC Viral Hepatitis website at the Perinatal Hepatitis B Prevention page. Excellent resources can also be found at websites for other organizations, including the Asian Liver Foundation, the Immunization Action Coalition, and Hepatitis B United. Next slide. In summary, to identify women and infants at risk for hepatitis B infection or from hepatitis B infection, screen all pregnant women for hepatitis B infection at the first prenatal visit of each pregnancy. When pregnant women are hepatitis B surface antigen positive, notify the perinatal hepatitis B prevention coordinators who will assist in case management. Ensure that the mother's original hepatitis B surface antigen test report is placed in the birthing facility records. Emphasize the importance of obtaining studies to assess the woman's liver disease early in pregnancy to increase options for care and treatment in collaboration with a liver specialist, and evaluate household and sexual contacts for chronic HBV infection or the need for vaccine protection. Next slide. To achieve elimination of perinatal hepatitis B transmission, administer timely post-exposure prophylaxis and assess infant outcomes with post-vaccination testing for both hepatitis B surface antigen and anti-HBs, and monitor the outcomes of the upcoming clinical trials that aim to reduce or eliminate breakthrough perinatal hepatitis B infection. Next slide. Together, we can eliminate perinatal hepatitis B transmission, and thank you very much.
Thank you so much, Dr. Murphy. You have given us all the critical information and the processes that we need to help address perinatal hepatitis B. Next, I would like to introduce Dr. Sue Wang. Dr. Wang is the Medical Director of the Center for Asian Health and Wellness at St. Barnabas Medical Center in Livingston, New Jersey, and she also leads the Chinese Health Initiative.
Hi, thanks for the introduction, Sherry. I just wanted to say I really enjoyed both Dr. Murphy and Dr. Hayashi's talks. I thought they were, just great in terms of providing the background and providing some great examples of what the federal government has been doing to help with this. And now I'll be talking a little bit more about what we did at the Charles B. Wang Community Health Center to actually try to prevent transmission in our patients and how we collaborated with different groups. So to start off, we're going to do a poll question as well. And this question is, if no vaccination or HB is given to an infant whose mother is Hep B positive and also has the E antigen positive, what is the likely vertical transmission rate? First choice is less than 25%, 25 to 49%, 50 to 70%, and lastly, greater than 70%. So if you can make your choice now, and we'll have the results in a couple seconds. So I just want to give a quick background while we're waiting for the results, that I was at the Charles B. Wong Community Health Center for 6 great years and was very privileged to be part of some really wonderful hepatitis B work there. And I just transitioned over to St. Barnabas Medical Center in London, New Jersey, which is close to where I live, and I'm excited to continue doing some work in New Jersey now in the hepatitis B area. So just to give you some background as to why my titles are so complicated. All right, so I think we should have an answer now, okay? And more than half of you got the right answer, that greater than 70% of babies would actually get hepatitis B infection if they were not vaccinated and if their mothers were E antigen positive. And I actually think it was hidden in, well, not hidden, but it was in Trudy's slide that the statistic is 70 to 90%. So this just goes to show you how important vaccination is. And if there were not the birth dose and the HB given at time of birth, then really the vast majority of patients, infants who are born to this high-risk group of mothers would get hepatitis B, infection. So, you know, I think we can say enough about how effective the vaccination and immunoprophylaxis are. All right, next slide. So just as a quick overview, as you would expect, the vertical transmission rates have declined as we have implemented hepatitis B screening in pregnancy and also the use of HBIG and hepatitis B vaccines. However, even with the immunoprophylaxis, vertical transmission still does occur in about 3 to 7% of infants, and there are some contributing factors such as high maternal viral load and even in utero transmission. And there has been some reports that up to 1,000 infants still get hepatitis B virus transmission at birth. So, and some of the other vertical transmission is actually not attributed necessarily to the mom's viral load, but to infants not receiving appropriate vaccination as recommended. And I'll talk about that a little bit more. Next slide. So just to give you some background about the Charles B. Wong Community Health Center, we are a FQHC, federally qualified health center, with 3 locations in New York City, and we serve a largely Chinese population in the greater New York City area. So in 2012, we served 45,000 patients, and our patients have quite a high prevalence of hepatitis B. About 12% of all of our patients do have the chronic infection, and that includes both kids and adults. So in about a year, we see about 720 pregnancies. We have a very active OB department, and about 15% of those, on average, it varies a little bit year by year, do have are positive for Hep B surface antigen. So about 15% of the pregnancies have are in mothers who have hepatitis B. So in looking in our records, we noted that from 2007 to 2010, there were 5 infants at CBWCHC who did acquire hepatitis B through vertical transmission. So what we did was to examine these cases to identify any gaps in care, and from those lessons learned, we formed the Hepatitis B Moms program. Next slide. So this is a table showing you a little bit more detail about each of those 5 cases, and I do think it's interesting because they're everyone's a little bit different. So looking at the first patient, the first number we have is what the mom's viral load was before delivery. So you can see of these 5 patients, all 3 of them, 3 of the ones that we did have data for had very high viral load. And so the first one was 118 million. Whether or not there was not a discussion of antiviral treatment, and there was no antiviral therapy given, and this mom had a C-section. There was HB given. The infant did leave for China, which is a common practice in our patients at anywhere from 3 to 6 months of age. Sometimes the mothers will send the infants to China for care, and then they'll come back later. But what happens in that time is that oftentimes we don't get complete records once the infant goes to China. And also, they may or may not do the post-vaccination serology test to document immunity in these patients. So, for this infant, the post-vaccination serology was not done until 35 months. So, which is way beyond what the recommendation is for CDC, which is 9 to 18 months. And so there were a couple issues that could have led to the transmission there. So for the second patient, you see it's also quite a high viral load. This is 1.4 billion. And there was discussion of antiviral therapy to the mom in the third trimester, but she opted out, and she had a normal standard vaginal delivery. HBIG was not given by the hospital, and all these infants actually did complete all 3 vaccines, and the infant did have a surface antigen test at about 8 months, and at this point we did see that the infant was infected. So this may have been due to the viral load and also the lack of HBIG being given. So the third patient, also high viral load, discussed antiviral therapy with the mom. She did agree to take it for about 6 weeks, and we found that she did get HBIG and was not sent to China, and the infant still was found to be positive at 10 months. So what we found, though, in this case is that she only received the antiviral therapy for 6 weeks, and her viral load did not decrease significantly. It was still 10 to the 8 copies per milliliter, and the general, what we're finding in a lot of literature is that if it's over 10 to the 6, they may still be at a higher risk of transmitting the infection. And for the last 2 cases, we don't have the records for the mothers. The mothers were not our patients, but the infants became our patients, and so we don't have a lot of clear data to know what some of the predisposing risk factors may have been. Next slide. So as I mentioned, some of the contributors, definitely high maternal viral load. It's well documented that mothers whose viral loads are over 10 to the 8 copies per milliliter do confer a higher risk, up to 30% chance of breakthrough transmission, even with the vaccines. So, and some of these mothers were offered antiviral therapy, and not all of them took it in these cases. So secondly, failure to adhere to clinical recommendations of screening, vaccine, and serology testing. As you can see, some of these infants did not get their HBIG and did not get the serology testing at the appropriate time. So, and then also there was an error in the hospital identifying one of the patients as hepatitis B. So it was a hand transcription error where the infant's OB records that were given to the hospital did indicate that she was Hep B positive, but whoever was transcribing it into the EMR documented Hep B negative. And so in the delivery room, she was not given HBIG because they did not know that the mother had hepatitis B. So, and then following that, the other patient that we looked at, post-vaccination infant serology test was done too late at 35 months, and possibly could have missed an important window of time where we could have revaccinated the baby prior to exposure. And one big gap in care we identified was just that we realized that the mothers were not really engaged in the Hep B care plan for themselves or their infants, and they were not really advocating in the hospital for themselves to make sure that the infants were getting vaccinated, and even with their pediatricians that the serology test was being done. Next slide. So as I mentioned, there are issues with identifying pregnant women at a hospital, and Seiji alluded to this in that some women may end up at a different hospital than they intended to go to if they were traveling, and so those hospitals may not have records. And we're at the day and age where we think that EMR communicate with each other, but in reality, a lot of EMRs from outpatient and inpatient do not communicate, and so we often do rely on paper charts from the OB to the hospital. So because of that, there are some issues, potential gaps where the information does not get relayed properly. So that also does occur within the hospital, between the delivery room and the nursery, where the nursery may not be aware that the mother has hepatitis B. So one of the things we were trying to do is to have the patient carry their own pregnancy passport, which has all their important information on it. So if records do not get to the hospital, she still has this pregnancy passport, which we've taught our patients basically to carry with them at all times during their pregnancy. And also we've taught our patients to just, when they show up to the hospital, they themselves can be the ones to tell their providers that they have hepatitis B and to make sure that their vaccines are done. So, and as I believe we'll be talking about more in the next talk, there are variable hospital protocols for vaccination, and not all hospitals have one. And oftentimes that can be a big determining factor as to whether the birth dose and the HBIG are given. So, and I believe Deborah will talk about some of the birth dose coverages And there have been many studies showing that birth dose coverage can vary, and it often depends on the hospital's policy. All right, next slide. All right, so these are the objectives of our program. Basically, we wanted to provide education to our patients, train the providers to know how to take care of hepatitis B, and then coordinate care between OBGYN, internal medicine, pediatrics, and the hospital. And we hope that applying care management would also ensure close monitoring of hepatitis B during pregnancy, including ensuring vaccination and the serology test following that. Next slide. So this is a diagram of our protocol. On the left, you kind of see what the clinical management is, and on the right, you see what the care management is doing. So our care manager provides in-personal, one-on-one counseling with each mother as she gets OB care, and we confirm that the patient has received care and follows the recommendations. She actually follows keeps a close eye on the delivery records and confirms that immunizations and serology tests are done, and keeps a database, and also collaborates with the Department of Health. Next slide. So this is our roadmap which we developed, and this is actually a bilingual educational flyer that we give to each patient, and it's in, so on the back it's Chinese, on the front it's English, and has a lot of visuals to basically tell the mothers exactly what needs to happen to their baby. We found this an easy tool for them. Next slide. This is something we developed as part of the program as well. We realized there was an additional gap in care, was that pediatricians were often not aware that the infant's mother was hepatitis B positive, and so would forget or would not actually order the post-vaccination serology to check for immunity. So we developed this Hep B perinatal exposure sticker, which you see here, which basically is added to the immunization card at the delivery hospital. And it has a place for the HBIG documentation. And this is, HBIG is not something that's otherwise on the immunization card. So right away, if the pediatrician is reviewing the immunization card, they'll see that the baby got HBIG, and it will trigger them to think about getting the vaccination, post-vaccination serology. So, as an additional step, we know that sometimes the doctors are confused and they're not sure exactly which test to screen for. So we actually have an area for them to write down the results for both the Hep B surface antigen and surface antibody. This is something that we were hoping would work as a bridge of communicating from communication to the OB. Next slide. All right, so our program, we enrolled 181 patients. The vast majority are Asian and from Fujian, which is a high-risk population for hepatitis B. And basically, they were followed through pregnancy until after the infants got their serology testing. Next. This is just a table showing you what the characteristics of the moms were. So as you can see, almost 25% of them were E antigen positive. 15 to 20% had really high viral loads. So we had a considerable number of patients who fall in the high-risk category. Next. And this just shows you the changing trends of antiviral treatment. So you can see in 2007, early on, people who were being treated with antivirals were being given lamivudine, which we now know has a high rate of resistance. And after tenofovir was approved in 2008, you can see the usage dramatically increases. One reason is that physicians were more comfortable with treating. There's more data out there about treating with antiviral medication, and also data about safety. Next. So this complicated looking diagram is really a kind of just looking at a timeline of infant follow-up. So on the left is birth, on the right is serology. And we are comparing our two groups, the 2007 to 2010 group to our actual treatment group or intervention group, the 2011 to 2012. And what I think you get out of this is that it's complicated in terms of following these patients, because there are a significant amount of patients who are transferring out and not following back up with us. They may be changing providers, or as in our population, quite a number of them were actually leaving to go to China for caretaking purposes, and we would not be able to document that third vaccine and also the serology test. So what we found at the end in the first group, we had 85% complete vaccination rate, and of those, complete vaccination, and then when we did the testing, we had about 4.2% transmission rate. Those are the 5 cases that we talked about earlier. And for our study group, and this is not complete, this was just up into the point, so we don't have all the results here. But of the 24 who did complete the vaccine and get their serology test done, all 100% were negative. So at this point, it looks like we do have a 0% vertical transmission rate, and even though the N is small, it's very promising. Okay, next. So finally, our conclusions, we really believe that comprehensive management in all Hep B pregnancies is really important and involves coordination between OB, the provider taking care of the pregnant woman who has hepatitis B, the delivery hospital, pediatrics, and local Department of Health. Accurate information exchange is really crucial to good care and and having all the instructions followed. And ideally that there would be some sort of data exchange between DOH, clinical laboratories, and the providers for sharing maternal labs and also vaccine completion rates. What we did notice was that towards the end, we did notice that and we don't know exactly if it's because of our program, but we did notice that sorry, this is a different slide, that we actually did have better completion of vaccines in our latter group. And as you would expect, we did have higher percentage of patients who were treated with antiviral medication. And I think that correlates with more data being out there about the effectiveness of treatment. Next slide. So as I mentioned, tenofovir is now predominantly the medication that our providers use, and I would say probably nationally more providers are using that for antiviral treatment in pregnancy. And we found that our culturally relevant patient education was really helpful in engaging the mothers and helping them ensure recommendations were followed. And they felt engaged and a little bit more in charge of their own health. And we told them that they could even take the Hep B roadmap that we had developed to the hospital. And even if they felt like the language barriers were so huge that they couldn't express to the care providers, they could give the provider the roadmap, and that would alert the care provider to give the vaccination. So, and what we found with our patients is that really the follow-up was very challenging due to family moves, changing of pediatricians, the infants relocating, and that was a real challenge to follow up. But we felt that care management was important and for infant retention, and we did find that as we started to counsel more and more mothers to try to keep their infants in the U.S. Until 6 months, that they were actually complying with us, and the vast majority of our mothers now are not sending their infants to China until after 6 months after completion of vaccines. So I think this is my last slide. So if there are further questions, this program is still ongoing at CBW, and if there are any questions, Dr. Vivian Wong is now the director, and we're happy to work and talk to anybody about developing a model similar to this. Thank you.
Thank you so much, Sue. I think the information you gave us will really help us not only understand the gaps and breakdowns that contribute to perinatal transmission, but there are some very successful components of your Hep B Moms program which can help us to address some of those barriers and some of those breakdowns. So thank you so much. Next, I would like to introduce Dr. Deborah Wexler. Dr. Wexler is a family physician who is also the founder and current executive director of the Immunization Action Coalition. IAC is based in St. Paul, Minnesota. It is the largest non-governmental provider of practical information on immunization to healthcare professionals and the public.
Should I go ahead, Sherry?
Go for it.
Okay, great. Thanks, everyone. Thank you, Sherry, and hello, everybody. What a wonderful series of presentations so far, and I'm really delighted to be the final speaker during this webinar. So what I'm going to be talking to you about today is IAC's new initiative directed at hospitals and birthing centers, and we call it Give Birth to the End of Hep B. Next slide. By way of background to our campaign, as all of you know, many newborns in the U.S. are not receiving the recommended first dose of hepatitis B vaccine at birth in the hospital. According to the latest CDC National Immunization Survey, and the statistics on the slide are 6 months old, only 72% of U.S. infants received the vaccine within 3 days of birth. And that's nearly a third of babies didn't receive it within 3 days of birth. And state coverage rates vary between 36 and 87%. So the statistics certainly show that there's room for improvement in protecting newborns in every state. Next slide. Why should we give hepatitis B vaccine to all newborns? Well, because hepatitis B vaccine starting at birth prevents mother-to-infant transmission, as you all know. Vaccination with hepatitis B vaccine alone at birth, without even giving HBIG, will prevent 70 to 95% of HBV infections among infants born to HBsAg positive mothers. It also prevents household transmission by protecting infants from infected family members and other caregivers. And importantly, Hep B vaccine starting at birth protects when medical errors occur. And you just heard from Dr. Wong about a medical error in her hospital setting by providing a safety net to prevent perinatal HBV transmission. Next slide. So why is a safety net needed? Because medical errors happen, and they happen often. Next slide. Some of the types of medical errors that we've heard reported from state perinatal coordinators are listed on this slide and include ordering the wrong hepatitis B screening test for the infant's mother. There are several hepatitis B tests, and some sound very much alike. HBsAg, hepatitis B surface antigen, is the correct test. Misinterpreting or mistranscribing the mother's hepatitis B test result, which we just heard about. Failing to communicate the mother's HBsAg test result to the hospital or within the hospital so that the infant is appropriately vaccinated. Not giving hepatitis B vaccine to infants born to mothers of unknown HBsAg status within 12 hours of birth, as is recommended. And not giving hepatitis B vaccine and HBIG to an infant even when the mother is documented to be HBsAg positive. Next slide. Because of these types of errors, children are becoming chronically infected with hepatitis B virus. A universal hepatitis B vaccine birth dose policy in hospitals helps to protect newborn infants from human error and the resulting chronic HBV infections, which can cause serious liver disease and deaths. Next slide, please. So the hospitals and birthing centers have an important opportunity to protect the future health of infants born at their facilities. Each year in the U.S., more than 24,000 infants are born to mothers who are infected with hepatitis B, and not all of these infants receive post-exposure prophylaxis. Most of these infants can be protected if hospitals routinely provided a dose of hepatitis B vaccine before hospital discharge. Next slide, please. Now I'd like to turn our attention to IAC's initiative to give birth to the End of Hep B, a campaign directed to hospitals and birthing centers to make sure that the birth dose is given to every baby before hospital discharge to stop HBV transmission at birth. IAC has created two major tools to promote the birth dose. The first is our new 85-page comprehensive guidebook titled Hepatitis B, What Hospitals Need to Do to Protect Newborns. And the second is the Hepatitis B Birth Dose Honor Roll. Both of these tools are available at immunize.org/protect-newborns. Next slide, please. I'm very pleased to tell you that our new guidebook has been reviewed and endorsed by the American Academy of Family Physicians, the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, and the Centers for Disease Control and Prevention. Next slide, please. The guidebook is divided into 5 sections. Chapter 1 is an overview about the importance of the hepatitis B vaccine birth dose. Chapter 2 addresses the topic of medical errors. Chapter 3 contains practical tools for hospitals to use. Chapter 4 provides hospitals with contacts who can provide support in implementing the birth dose. And the last section is an appendix, which provides excellent resource materials. The link on the slides that follow and this will take you directly to the book online. And now I'm going to briefly highlight each section of the book. Next slide, please. Chapter 1 is titled Preventing Hepatitis B in Newborns, What's Needed. It contains the executive summary, which provides the rationale for administering the birth dose to all babies before discharge. It also provides information about the newly established National Quality Forum's measurement of newborn hepatitis B vaccination coverage in healthcare settings. So the link at the bottom of each slide will take you directly to that chapter online. Next slide, please. Chapter 2 provides readers with 5 different articles describing serious medical errors that have been reported in healthcare settings. The first article is a 4-page summary article written by IAC after we surveyed all of the nation's perinatal hepatitis B coordinators. The second article is a tragic case report about the death of a 3-month-old infant in Michigan who wasn't vaccinated at birth because of a transcription error, and this baby died from overwhelming hepatitis B infection. The third article documents 6 case reports of medical errors that happened in the state of New York. And the fourth article contains 2 case reports from the state of Colorado. And the last article was authored by me and summarizes the problem of medical errors. Next slide, please. Chapter 3 is titled Addressing the Problems, Practical Tools, and this slide is about tools for use by hospitals. First article listed will help hospitals develop written policies which are so important for making sure pregnant women are appropriately screened and that all newborns are fully vaccinated and properly managed in the hospital. The second article, titled Sample Text for Developing Admission Orders in Newborn Units for the Hepatitis B Birth Dose, is text that can be cut and pasted and of course modified as desired by hospitals for placement into newborn admission orders along with all other orders like vitamin K, I, antibiotics, to make sure that every baby in the nursery receives hepatitis B vaccine routinely, just like all other routine newborn treatments. Next slide, please. Next slide, please. This is the image of the 2-page sample text for that I just described on the previous slide. Next slide, please. Chapter 3, these are tools for parents. It includes information about the hepatitis B vaccine information statements, and they're reprinted in both English and Spanish. And this section also contains IAC's newly designed handout for parents titled Hepatitis B Shots Are Recommended for All New Babies, which I'll show you on my next slide. Chapter 3 also contains information about the importance of parents having a child immunization record card and where hospitals can obtain them. Next slide, please. Here's an image of the front and back sides of IAC's handout for parents. It's free to download from our website and to copy and distribute. Next slide, please. Chapter 4 provides hospitals with contact information for state and local perinatal hepatitis B coordinators, as well as for the Vaccines for Children programs in all states. Next slide, please. The last section, the appendix, authoritative resources contains 3 sections. First, a reprint of CDC's ACIP hepatitis B recommendations for infants, where we've inserted yellow highlighting to draw attention to some of the most important ACIP guidance. Second is a reprint of a journal article from Pediatrics that includes discussion of medical errors that occur in birthing settings. And the last section of the appendix provides additional resources from CDC, AAP, and ACOG. Next slide, please. Oh gosh, the image isn't showing on this slide. That's unfortunate. So, well, what's seen on this slide that you can't, I would like you to see on this slide is some yellow highlighting. Maybe we could go back to the previous slide, because what that yellow highlighting brings out are the 13 places in the ACIP recommendations where the exact language of the recommendation that stresses the first dose of hepatitis B vaccine is clearly recommended in the hospital before discharge, rather than delaying the first dose until a subsequent office visit, which is a big problem and a common practice. And so what I wanted to show you on the slide was, I had highlighted in yellow, as you can see, the recommendation says, on a case-by-case basis, and only in rare circumstances, the first dose may be delayed until after hospital discharge. Let's go on to the next slide, and then the next slide. And now that you've heard about the new guidebook, I'll tell you about the hepatitis B vaccine birth dose honor roll. IAC launched the honor roll in July of 2013 in Albany, New York, honoring Albany Medical Center, a 630-bed hospital with 2,100 births per year, as the inaugural honoree and enrollee. They achieved a hepatitis B vaccine birth dose coverage rate of 99%. We hope there will be thousands more hospitals and birthing centers that will be similarly honored. Since the end of September of this year, when we launched the online application form for the honor roll, we have honored at a total of 50 hospitals in 19 different states by including them in the honor roll. The honor roll recognizes hospitals and birthing centers that have attained 90% or greater coverage for administering hepatitis B vaccine at birth. And you can just use the link on this page to find the honor roll page. Next slide, please. The criteria for the birth dose honor roll, there are many, but the 2 main ones are, number 1, that at least 90% of babies, regardless of their weight, born during a 12-month period, receive hepatitis B vaccine prior to discharge, and that includes those infant parents refuse. The second major element is there must be written policies, procedures, and protocols in the hospital or birthing center for implementing the universal hepatitis B vaccine birth dose. And several criteria are also included, which you can see on the slides, but I'm not going to take the time to read. So next slide, please. And then we can skip from this slide to the next slide, please. All this information is available on our website, all the criteria, so that you can see them. Enrollment into the honor roll happens like this. Applications are accepted at immunize.org/honor-roll/birth-dose. IAC reviews the applications, and then we notify applicants of their acceptance, and we mail them a certificate of enrollment suitable for framing and display in their hospital. Hospitals and birthing centers' names and corresponding state are listed online on the Birth Dose Honor Roll webpage on IAC's website. And we also announce the birthing institution's name in IAC Express, our email news service that goes out to 50,000 health professionals every week. And if you haven't subscribed, you can do so by going to the link at the bottom of this slide. Next slide, please. Here's an image of the certificate that was awarded to Albany Medical Center. And we send out similar certificates to every hospital who is accepted into the honor roll. Next slide, please. The next slide shows more links and information about the Honor Roll campaign materials that you can access and look at. Next slide, please. So here are some things that you can do to help move the birth dose campaign forward at your institutions. Number one, you can download the free guidebook, Hepatitis B, What Hospitals Need to Do to Protect Newborns, from our site. And you share it with others, hospitals and birthing centers who you think would be interested in using it, which we hope would be all of them. You can share the guide with hospitals, with birthing centers to help them improve their birth dose coverage rates. Then we have 2 handouts you can distribute. One of them is called Give Birth to the End of Hep B, which is created to educate hospitals and healthcare professionals about why the birth dose is so important and about this initiative. And the other handout is Do You Qualify for the Birth Dose Honor Roll, which encourages hospitals to apply, including those with whom you are affiliated. And lastly, if you're a hospital and you've achieved 90% or greater birth dose rate, or you think you've come close, please apply for enrollment on into the Birth Dose Honor Roll. We would love to have you included. Next slide. Next slide. This is the campaign piece that we've developed to promote the birth dose that gives, oops, I think we skipped one. Okay, that's right. This is the one that promotes the campaign, tells people why the birth dose is important and where to get the materials. And the next slide, please. This is a handout sent to hospitals to encourage them to apply for the Honor Roll. It's available in black and white and color and downloadable on our website at this URL. Next slide, please. And this is my second to the last slide, which demonstrates so clearly why we all do what we do. Next slide, please. And thank you, everyone, for listening today. I hope you'll visit our website, www.immunize.org/protect-newborns, and download our materials and share them with others. And if you have any questions about our campaign or about the OWL, just email birthdose@immunize.org. Thank you so much.
Thanks very much, Deborah, for sharing all of those very new and very important tools that we can all use to address perinatal hepatitis B transmission in our own communities. At this point in the webinar, we are going to switch over to our question and answer section. What we're going to do is start by answering the questions that have already been submitted. If you would like to submit a question now, you can still do so by using the question field on your screen. Just please try and indicate who your question is directed to. Okay, our first question is addressed, I believe this is for Dr. Trudy Murphy. It says, I wanted to ask if there is any evidence or studies pertaining to mother's breast milk and transmission of HBV. To narrow the question, I am interested in mothers with a high viral load or E antigen positive, and also in cases where an infant may not have received PEP.
Thank you very much, Dr. Cohen. William, I think this is a really important question because we want to encourage mothers to breastfeed. Hepatitis B virus is found in breast milk. There have been a number of studies that have looked at women who are breastfeeding and whether or not the baby received HB and vaccine or did not receive HB and vaccine. And if they received vaccine and HB, then women who are there is no difference in the outcomes of the babies between those who breastfeed and do not breastfeed. So we can easily recommend breastfeeding for women whose babies have already received vaccine and HB. Now, none of the studies that have looked at this have divided women into those who have high viral load and low viral load. Most of the people who were studied in these studies, though, had low viral load. If a baby has if the mother has a high viral load, whether or not the baby is breastfed, that baby is at increased risk for transmission. And it is unclear how much additional risk the breastfeeding would contribute. Probably not much, because the risk is already so high. If the mother has a low viral load, then it is very likely that the breastfeeding will not make a difference as long as the baby receives normal prophylaxis with vaccine and HBIG. I hope I've answered your question.
Thanks very much. Question 2. I believe this one is for Dr. Sue Wong. Did patient number 2 have labs repeated after 8 months since they were done prior to the recommended 9 months, or is it definitely considered positive no matter what?
That's a good question. Yeah, the recommendation is to test at 9 months, or it could be 1 to 2 months afterwards. So this was not the only test that was done, but it was the first test. I believe the suspicion was fairly high that the infant might be infected, so they did it a little bit earlier. And they did do follow-up, and of course you would have to do a viral load, the HBV DNA to confirm as well. So thanks.
Thank you, Sue. I believe the next question is for you as well. It says, I noted that none of the 5 cases that you presented were breastfed. Is that related to their Chinese background, or is it that you do not recommend breastfeeding if a mom is Hep B positive? I was always taught it was okay to breastfeed.
Thanks. Yes, we do encourage breastfeeding, but as you note, Leah, that the breastfeeding rates are not high in our population, and it's something that we've been working on with our OB department to try to increase education for all patients, to all moms, to breastfeed. And there's just some, I don't know, there's just some cultural reasons why the women are not as keen to breastfeed. But we do tell them, as even with hepatitis B, that as long as the baby is prophylaxed and receives the vaccinations, that they're not at any increased risk to transmit to the infant. Our one caveat, though, is that the mom not have bleeding or cracked nipples, and if they do, because there's a chance that of higher transmission, then that we would avoid breastfeeding if they have issues with their potential bleeding. But it is actually recommended. We tell them that AAP, the American Academy of Pediatrics, and WHO both encourage and recommend that Hep B mothers breastfeed.
Thank you very much. The next question I'm going to field over to Trudy Murphy. It says, I don't believe that women are treated during pregnancy in our area. Is there an official recommendation for this, and how can I get the message out?
Thank you very much. There is not an official recommendation for treating women during pregnancy, except for, as indicated, for their chronic liver disease. And there are recommendations for treating people who have very active liver disease. That's why the trials are being conducted, to demonstrate what would be an adequate regimen, what's the most effective regimen, how long should women be treated, and how much benefit can the baby receive from having it. However, having said that, anecdotally we hear that there are many hepatologists who are treating pregnant women who have high viral load.
Thank you. Next question is for Sue. It reads, is the maternal roadmap available for outside use and distribution? And if so, where can I access it?
Yes, it is. We're happy for other people to use it. It's available through Charles B. Wong Community Health Center, our education department. It may be on our website. I'm not 100% sure, but if it's not, we can get it to our website, or you can email anybody there, and we're happy to provide it to you. And just going really quickly back to the last question that Trudy answered, there are some, if there are people in your area interested in treating the AASLD, the American Association for the Study of Liver Diseases, they do have some, guidelines that can be followed, or recommendations in their hepatitis B recommendations. So that's, one professional resource that you could provide to your providers. Thanks.
Thanks, Sue. Next question is back to Trudy. It reads, in terms of measurement of dangerous viral loads, Could you expand on that a little to help me understand the measurement, and when do providers decide to measure the infection through viral load, or is it only during treatment? Would it help if we could measure it after finding out the HBsAg is positive?
Yes, the additional testing would be done in any person found to have chronic hepatitis B, according to the AASLD recommendations, and would include some of the tests I mentioned, but there are additional tests that AASLD would recommend. The special screening that is now being recommended for women who are pregnant includes the hepatitis E antigen and or hepatitis B DNA, which is a quantitative test, as well as liver enzymes. And I'm sorry, the question broke up when it was being read, so I hope I have answered your question. Otherwise, I'll need to hear it again.
I think that covers it. Thank you.
Okay.
Next question is for Sue. Is your state developing a Department of Health vaccination database that is accessible by all providers? Our state, Hawaii, has developed a state vaccination database that's supposed to house all children's vaccine histories. Our CHC is developing an interface to be able to access that data so that we can see the child's vaccine history. This might be a helpful project for all states so that if a child moves to another state, the provider won't have a gap in care.
Yes, this is a great question. New York does have a citywide immunization registry, CIR, which is actually online, and anybody can access it who's a provider. You just have to apply for a login. And so this is hugely helpful when the pediatricians change and you need to get actual good records. What we found that was tricky for our patients is that they often received the third dose out of the country, and so they would not be able to document that as a vaccine given. But we were able to work with the Department of Health, and we figured out a way where they could still indicate that the vaccine was given, but it was given outside the country, but we could at least see that it was documented by somebody as being given. I found in New Jersey, since I've started working here, that New Jersey does not have a registry that's accessible in the same way. So I do believe, I do think that if all states could have that, that would be really great for patient care.
Great, thanks. The next question is for Dr. Deb Wexler. Will the toolkit be available in Vietnamese or Chinese anytime soon?
I don't know if it was our toolkit or the one from CDC, but no, we aren't planning to unfortunately, any of our materials. It was just a really big job to even complete it in English, so we don't have any plans to do translations, I'm sorry to say. We do have the brochure, the one about babies that we created for parents. That is available right now on our website. It's kind of the old design of the piece, but the information in it is correct, and that is available in Chinese, Vietnamese, Spanish, several languages. If you just Google the title of the piece, I think hepatitis B vaccine is recommended for all newborns, you'll find several languages of the piece. And of course, the vaccine information statements, we only include English and Spanish in the book, but those are available probably in 30 languages on our website at immunize.org/VIS for vaccine information statement. So all the VISs in many, many languages are available on our VIS web section.
Thank you. We do have at least 5 or 6 more questions. I know it's getting close, or it actually has just now turned 4 o'clock. But if you bear with us, we're going to try and get through as many questions as we can in the next few minutes. The next question is for Dr. Sue Wong. Would you recommend that the obstetrician run the E antigen and the viral load test, or do you recommend that the woman be referred to a specialist?
That's a good question. We know that a lot of OBs do feel a little overwhelmed by ordering additional Hep B testing and being responsible for interpreting them. And so I think it does depend on the patient and whether they're already getting care for hepatitis B. or whether you know that they would actually follow up and see a specialist. What I would like, and I think this would help with care, is that if the OB would at least order the e antigen and viral load, and when it comes back, if they see right away that the e antigen is positive or the viral load is really high, then you're able to counsel the patient that they are considered high risk and even more strongly recommend that they see a specialist. We know that there are quite a number of women who are recommended to see specialists and actually don't, and so this would help improve the follow-up, we believe, if the OBs would actually order, could order initial testing, or at least develop really close relationships with doctors that their patients, that it would be convenient for the patients to see.
Thank you. Next question is for Deborah Wexler. As an increasing number of women opt to do home births, is there any attempt towards discussing these recommendations with midwives from organizations like ACNM and MANA to talk about covering these babies?
That's a great question, and it's a real challenge. From our perspective, we're going after the hospitals first because we know that approximately 70% of babies are getting the birth dose, but we have, we can get a lot more traction and a lot more babies if we go to the hospitals first and birthing centers. However, all of these materials are free online, and that's a good suggestion. We have a contact at the American College of Nurse Midwives who would, I'm sure, be happy to help us to get this to, throughout her organization. So thank you for the suggestion.
Thank you. The next question I'm going to shoot over to Dr. Trudy Murphy. Are there any protocols in place for pregnant women, it looks like for pregnant women who are co-infected with HIV?
There are protocols there are some that are being developed, and I think that there are some. I'm sorry, I'm not familiar with the exact source of those protocols, but that's a very important aspect of HIV care, is those who are co-infected. And if you contact me, we can certainly find those for you.
Thank you. Next question I'm going to field over to Deborah. How should we counter the argument that parents often pose that infants not born to HPV-positive moms can get the first dose of vaccine during their routine pediatric follow-up rather than in a hospital just after birth?
There are a number of ways. Actually, we're working on at IAC, we're working on a piece right now to answer those arguments about, why do you need to vaccinate babies at birth when they could get it in the doctor's office? But we're very concerned about, number one, the medical errors that occur that we've heard about on this call today, that those are happening whether we even see them or find them or not. They're happening regularly, and we don't know when they're happening because they don't come to light, but we know reports are mistranscribed. Even if everything's done in the practice and the results are sent over to the hospital, sometimes the hospital doesn't vaccinate the baby because they don't have it as part of their routine. So we're trying to make sure that every baby gets protected so that there aren't any babies falling through those cracks. The other concern is, what about the time from birth when the baby is being taken care of at home and exposed to others who could potentially have hepatitis B, and the baby could contract the infection? So there's just, there's a timing period there when babies can be exposed, and there's the medical error piece where babies can be exposed because their mothers are actually infected and it wasn't known at the time of birth.
Thank you very much.
But we will, yes, and we will be developing that piece, and I'll be happy to, we'll be announcing it in IAC Express when it's ready, and it will be on the Birth Dose website as well, the Protect Newborns website.
Thank you. Next question is for Dr. Murphy. What % of those infants immunized with the Hep B vaccine do not develop a measurable titer and become protected?
What % don't become protected?
Yes.
It's probably in the 5% range. and many of those babies will become protected with another set of vaccinations. I should mention, though, that what we've recently found is that the timing of doing the post-vaccination testing does become important in making sure that you're going to get a positive anti-HBs if it's going to be positive at all. And that's if you wait a long time after the child's last dose, then the titer can drop over time, and you might think that it's negative when it would have been positive if it were measured 1 to 2 months after the last dose. The reason for waiting until 9 months of age is that when HB is given at birth, it sometimes prolong the incubation period, and what you don't want to miss is a baby who is infected because their incubation period had not been completed. And so we wait till 9 months to make sure that we've identified all the babies who were infected, and then as soon as possible after that, as long as it's been 1 to 2 months, is the ideal time for checking for antibody after vaccination. So it's about 5%.
Thank you. There are a number of questions that we were not able to get to, but it's kind of getting late. Thank you so much for your patience and for staying with us for a few extra minutes. We are going to make sure that we do answer and follow up on every question that was submitted to us today or before the webinar. So please be patient with us, and we will make sure that we send out an email. The email will have the link to the webinar slides and the audio, and we will also answer whatever questions we were not able to get to today. In addition, you can also contact Hep B United at hepbunited.org if you have any additional questions, information, or concerns. I would like to thank our wonderful expert speakers today. Thank you so much to all 4 of our speakers who really, they stuck with it. We were supposed to do this back in October, and due to the shutdown, we had to push it off to December, but our speakers were gracious enough to do this for us today. And thank you to everyone who participated. On behalf of Hep B United and the White House Initiative on Asian Americans and Pacific Islanders, thanks for joining us. And please stay tuned. Hep B United will continue to have webinars in the coming months ahead, focused on how we can use all of the new tools that are in place to address hepatitis B. Thank you again, and enjoy the rest of your day.